Hi, everyone. My name is Liuan Huska, and I'm a freelance writer and author of the book Hurting Yet Whole, Reconciling Body and Spirit in Chronic Pain and Illness, which released last year with InterVarsity Press. It's an honor to be here presenting when all of you who are in the Christian community health space, who are seeking to love God and neighbor better through caring for body, mind, and spirit. I'm also really honored that you chose to participate in this workshop because chronic illness, especially among marginalized communities, is really challenging to treat. There are so many layers from personal to interpersonal to societal that feed into the kind of suffering that people with chronic illness experience. And the ongoing nature of this kind of suffering um, makes it hard to offer a consistent and ongoing level of care and compassion when we're walking alongside someone with chronic illness. So I'm not trained as a doctor or healthcare provider. I have a BA in anthropology from Wheaton College and a master's in social sciences from the University of Chicago. But what led me to this topic is my own experience of living with chronic pain, which started in my early 20s, and the frustration that I felt navigating the medical system on my own, as well as the frustration of not feeling understood or well supported by my faith community. One of the regular messages that I got from other Christians was that I could be well as long as I was spiritually well, as if I needed to ignore my body and the discomforts in order to live a good Christian life. But I think we would all recognize, especially in the community health sphere, that we can't separate out just our spirits or just our bodies, or just focus on either systemic health issues or individual health issues. We know that healing happens on a whole person level, body, mind, and spirit. And beyond that, we know that healing goes beyond treating a single person, but that we also need to address the dysfunction within our social, political, ecological, and economic systems as well. So that's what led me to write the book, Hurting Yet Whole. I wanted to explore what healing could mean for people with chronic illness beyond just focusing on spiritual things and beyond just the individual. So that book tells my personal story while weaving in theology, sociology, anthropology, and other parts of people's stories whom I interviewed while writing the book. I offer a multi-layered understanding of healing, not just as physical or spiritual wellness. That isn't just about the individual person, but includes community and society and the ecological systems that we're part of. So, in this workshop, we're going to explore some of those different layers of healing, and I'll share some concepts that have helped me to develop a more robust understanding of healing. So, let's start on the societal level. In the United States, the CDC estimates that 6 in 10 Americans live with some form of chronic disease, including heart disease, cancer, or diabetes. And of all the chronic illnesses, there's a subset that some have called invisible illnesses that are harder to diagnose and treat because they don't always manifest in measurable, obvious ways. These include fibromyalgia, rheumatoid arthritis, lupus, chronic fatigue syndrome, and many, many others. And as we're learning, many of these invisible illnesses are related to immune system functions. And even the more recognized illnesses like diabetes have an immune component. We also know that about 75% of autoimmune disease sufferers are women. In my book, I devote a chapter to exploring the reasons why women are more prone to autoimmune diseases, which includes elements of biology, but also structural inequities in the stress of living in the world not set up with women's interests in mind. Another thing we know about chronic illness is that it's not evenly distributed across society. So that's why we're all here at this conference, because we can see in our communities that some folks have better access to preventative care, healthier foods, and safer neighborhoods, while others don't. And that leads to a huge disparity in health outcomes across socioeconomic statuses. There's a higher prevalence of obesity, diabetes, heart disease, maternal health complications, and many other kinds of chronic illnesses within underprivileged communities. So, at this conference and in our daily work, we're here to be part of the solution in addressing these disparities because our faith calls us to stand with the least of these, as Jesus taught. So, one of the things I think we lack as we think about serving different underprivileged groups is a framework for understanding how different kinds of injustice, like racism or misogyny or ableism, might interact to affect people's health. So, to explain what I mean, let me share a little bit of my own story here. I started to realize early on in my years of chronic pain that being a woman was part of what made my experience in the medical system so frustrating. And that's something that I heard from many of the women whom I interviewed in the process of writing my book. One of the most frequent themes I heard from women was this sense that medical professionals were dismissing or minimizing of their pain because women were perceived as too emotional or in their head, or that they needed to see a psychiatrist rather than receive pain medication. So, exploring what it means to be a woman in a woman's body and how women are treated in society and within the medical system has been a big part of my own healing journey. Only more recently, I've begun to unpack how being an Asian American and a child of immigrants has also impacted my health. So, I came to the United States when I was 3 years old from China. Being a Chinese immigrant affects how I'm perceived by doctors and nurses, my communication style, and the stresses I've experienced moving around a lot in my childhood and not having consistent medical care, which all factor into my current health. So, not only does being a woman affect my health, so does being an Asian American. Um, and then being an Asian American woman is the intersection of those two identities that adds an entirely different layer to explore. So that's something that became really clear to me when the Atlanta massacre happened back in March of this year, when a young white man walked into several spas in Georgia and killed 8 people, including 6 women of Asian descent. So the wider public argued about whether this was a crime motivated by race or gender. And what I and many other people concluded is that the answer is both and. Asian women are uniquely vulnerable because of the history of how we've been treated in this country. So, just a tiny bit of background on that. The first Asian women to immigrate to the United States were Chinese women, essentially brought over in sexual servitude, sometimes kidnapped from their homes in China, or sometimes told they would be getting domestic worker jobs in the United States and then tricked into prostitution. So, exploring some of that history and how that's played out in how Asian women are still perceived in American society has helped me to understand my own stress levels and health in this larger context. And it has helped me to unpack other factors that intersect with being an Asian woman, like being an immigrant, growing up as one of 2 Asian families in an all white town, the financial difficulties of my childhood, cultural dislocation and disconnection from extended family, my parents' divorce when I was 10, which um, all play into my health and how I experienced chronic pain in in the early years of my 20s. So the concept that has helped me articulate all of that is called intersectionality. You all might have come across this term. It's become a hot button word in recent years, along with other words like critical race theory, identity politics, and so on. It was coined originally in 1989 by the legal scholar Kimberly Crenshaw. She wrote a paper that analyzed 3 cases where she felt that the court's view of discrimination was too narrow because it didn't take into account that the women who were the plaintiffs were both Black and female, and thus subject to discrimination on the basis of both, often a combination of the two. So the courts had argued that Black women couldn't be considered a separate protected class, but Crenshaw argued instead that yes, Black women should be considered differently than Black men or white women because different layers of marginalization, when they're intersecting in one person or a group, makes that person or group more vulnerable to discrimination. So intersectionality in the past couple decades has been applied to a lot of areas outside of the legal system, including healthcare. So here's one definition of intersectionality as it applies to healthcare. Intersectionality is the ability to view individuals and communities from a complex and dynamic perspective, knowing that not only one or two characteristics, such as race or gender, affect who they are and their health and well-being, but recognizing that people are multifaceted, people come from specific places, cultures, religions, languages, and ethnicity, and they have a place in society in terms of power and privilege they hold. Intersectionality is a recognition of how all of these factors affect who we are, how we act, how we practice, and where we end up in terms of our health and well-being. So I know that's a pretty big definition. So let me just give you some bullet point characteristics to intersectional medicine. So there's an attention to power and privilege. So we're looking at the patient's position in society and the provider's societal position and the power dynamics within that. And there's also an awareness that the layers of marginalization aren't necessarily cumulative, but interact differently when it comes to each individual. So, for example, being an Asian and a woman doesn't mean that I have 2 times the level of vulnerability of a white woman, but it just means my experience of illness in the medical system is going to be different than that of a white woman or an Asian man. And so, intersectional medicine is asking how and what those differences are and how they play out. And intersectional medicine understands that minority groups aren't homogenous. So there's not a one size fits all perspective. And related to that, it's not isolating one issue. So we're not just looking at mental health or Muslim health or women's health or housing, but we're trying to understand how all of these different aspects might intersect in any given person's situation. So there's a quote from a paper in the Lancet, which I really appreciate. It says, intersectional medicine rejects the idea that one system of inequality is more important than any other. Different inequities are intertwined and experienced simultaneously. So let's apply this approach to another example. We know that Black women in the US die at 3 to 4 times the rate of white women from childbirth related causes. So an intersectional perspective asks, why are Black women uniquely vulnerable compared to other groups, such as Latino women or Indigenous women or Asian women? What else is going on in terms of access or trust or distrust in the medical system, postnatal care and follow-up? How does job security or access to insurance make a difference? What about neighborhood? How do maternal outcomes compare when we're looking at African American descendants of slaves versus more recently arrived African immigrants? How does religion and religious support factor in? How does being a Black queer woman affect maternal health? So there is a ton of overlap between intersectional medicine and the Christian Community Health Fellowship approach. Both are trying to see people as embedded within their communities and societies and as complex, integrated body, mind, spirit people. So in some ways, I might be preaching to the choir when I'm bringing up this approach. However, I think there are specific strengths that we can harness with the intersectional medicine approach, which is essentially a really deep and nuanced understanding of all the cultural and social factors that make people who they are and affect their health. I really wish that all medical students were required to at least minor in one of the social science fields, because seeing how biological conditions are intertwined with political, economic, environmental, cultural, and social conditions is going to make our delivery of healthcare and our ability to serve our neighbors so much more effective. What I think we can offer as Christians in this field is an even more expanded vision of what it means to be a whole person and a complex person, including the spiritual dimension. But often, at least from my experience, Christians have focused on the spiritual aspect to the neglect of other dimensions of our personhood. So this is where community health providers have a unique opportunity to model the both and holistic approach that Jesus calls us to. We are about healing both individual and society, body and spirit, family members and family systems, healing human bodies and the body of the earth, because it's all connected. It's all part of what Jesus wants to redeem. So, how does this understanding of whole people and intersectionality apply to living and walking alongside people with chronic illnesses in a community health setting? We start to see when we begin to explore all the layers that affect our health that healing is an ongoing process that affects all aspects of our health and happens at all levels. Sorry, I lost my, 1 second, I lost my, there you go. Healing is a process that happens at all levels. As doctors, nurses, and administrators, we start to see ourselves and our patients as embedded within this bigger community and societal fabric. So we might be focusing on individuals with chronic conditions, but we know that we're not going to bring them up to optimal health in 1 or 2 visits or even with ongoing medical care, because there are all these other upstream factors. So many community health practitioners are already asking the important upstream health questions, like how is someone's asthma related to the mold in their house, and how can we deal with housing issues? Or how is another person's cardiovascular disease related to lack of access to playgrounds or other forms of outdoor activity? Or all these questions about gender, race, sexual orientation, immigration, family situation, and how they intersect with each person's health. So if you're a leader of any kind, whether that's within community health or a more conventional medical system, talking about these factors and advocating for deeper training around intersectionality and upstream determinants of health is so important. I also think that an intersectional approach reduces the burden on doctors and nurses to be the ones that fix everything. It helps us to see healthcare providers as collaborators. Rachel Naomi Remen is a former medical professor and currently a therapist to cancer patients, and I found out about her work through Krista Tippett's On Being show. She writes in her book, Kitchen Table Wisdom, years ago, I took full credit when people became well. Their recovery was a testimony to my skill and knowledge as a physician. But then she goes on to say, I never recognized that without their biological, emotional, and spiritual processes, which could respond to my interventions, nothing could have changed at all. All the time I thought I was repairing, I was collaborating. And so she concludes by saying, we are all providers of each other's health. So I thought this was such a powerful acknowledgement of the many forces that are beyond our control as healthcare providers, but which we can become aware of and work with. And so what does this mean for when we encounter a person who has chronic illness at our clinic or office or hospital? The first step, if we're practicing the incarnational way of Jesus, is to offer our presence and compassion. In Mark 9, when Jesus encounters the father of a child who's demon possessed, who's getting thrown to the ground and foaming at the mouth, the first thing that Jesus asks the father is, how long has this been happening to him? In other words, Jesus asked the father to tell their story from the beginning. I can just imagine the relief that the father felt to have someone look him in the eyes and listen to his whole story. Jesus didn't first ask, what are the symptoms or what level of pain are you experiencing from 1 to 10? Although those are important questions that should be asked later on. But he starts by giving the father of the boy the space to share what is important to him about his story and how it's been affecting his life. There's actually a newer branch of medicine that does exactly what Jesus is doing here. It's called narrative medicine and was founded as a master's program by Dr. Rita Sharon at Columbia University. And it's now being offered at more and more medical schools across the country. So, narrative medicine essentially teaches doctors to draw out and understand what patients are telling them as a story, a narrative. Narrative medicine training in literary theory, philosophy, narrative ethics, and creative arts increases clinicians' capacity to perceive the turmoil and suffering borne by patients and to help them cohere or endure the chaos of illness. And that's from Dr. Rita Sharon's edited book. I think the narrative medicine approach is really consistent with the Christian faith, where we understand the Bible as God's grand story of creation and redemption. And all that we do as Christians, we're trying to understand how our story gets enfolded into the gospel story. So here's another quote that I really appreciate. It's easy for patients to get reduced to a specific illness. Narrative medicine is a way of integrating everything back together. It's a way of staying curious about people. Ultimately, it's a form of love. So when we ask people to tell their stories, we're giving them permission to bring all of these strands of their identity, whether that's being a woman or a person of color or an immigrant or a trauma survivor, someone who's lived through poverty. We're affirming that paying attention to all these things is part of what it means to be a whole person and part of taking care of our health. Ultimately, it's not even just seeing the people that we serve in a holistic way, it's also seeing ourselves as healthcare providers in a holistic way, because we offer so much more than our analytical medical skills, but also our hearts and our stories and our imagination and our empathy and our creativity. So hearing our patients' stories is one practical takeaway from an intersectional approach to chronic medicine, to chronic illness. So another thing we can do is communicate the value in vulnerability in these settings where we're interacting with people with chronic illness. Paul in 1 Corinthians 12 talks about how, as the body of Christ, we are to honor and center the weakest members, those that receive less honor in wider society. And in Matthew 20, Jesus talks about how in God's kingdom, the last will be first and the first will be last. So I think an intersectional approach helps us to identify those who've been made the most vulnerable in our society, those who are last. And then our faith gives us the resources and the compelling motivation of love based on God's love for us to put these people at the center. So when we're meeting with people in a clinical setting or out in the community or in our churches, our message shouldn't be, oh, you're broken, let us fix you, but rather, I see your suffering. I mourn with you. You have a story to tell that can transform the rest of us. You have something of value to offer to our community. That's a message that I wish I had heard more when I was in the worst of my pain and all the depression and anxiety that came with it. I wanted my brothers and sisters in Christ to see me not just as a project to work on or someone to pray with in the aisles of the church, but rather as a valuable and even a central member of the community, because Jesus centers the most vulnerable and the most marginalized. So, given all of that, how can we offer people with chronic illness in our communities a different vision of healing? Knowing that their health conditions might be ongoing and realizing they're not just a problem to be fixed. What I discovered in my own journey is that healing is not so much about getting rid of illness or pain, but it's about right relationship and connection to my own body, but also to God and to my community. The disability scholar John Swinton writes that the closest word for health in the Bible is shalom. And the root meaning of shalom is wholeness, completeness, and well being. So this is a quote from him. Shalom is not the absence of illness, disease, or disability. It has to do with the presence of God. Healing always has, first and foremost, to do with connecting and reconnecting people to God. So we start with that, with relationship. We connect with the patient on a person-to-person level. We hear their story. We start to make the connections between their story and these larger stories that are happening within our communities and societies that have to do with injustice and inequality and the way things have been broken in our world. And ultimately, we see our stories and our patients' stories in light of God's story of making all things new. When people feel seen and heard as complex human beings, when they feel accompanied and valued in their suffering, that makes a huge difference for their well being, as I can attest to in my own story. So, the questions I would leave you all with: how can we foster healing as shalom, right relationship within our communities? How can we right those relationships on a personal, interpersonal, and societal level? And how can we invite those that we care for into these kind of relationships as collaborators, as not from just a top-down perspective? So I think exploring those kinds of questions will make all the difference in our work and in the lives of those we serve. So thank you all so much for joining in this workshop. And I think we have some space for asking questions. After this, I also want to leave you all with some resources. If you're interested in reading further on any of these topics, there's my book, obviously, Hurting Yet Whole, Reconciling Body and Chronic Pain and Illness. And also, if you go to my website, which is highlighted in blue, you'll find some other resources and readings, including a series of meditations that a friend and I put together for those who are experiencing chronic illness and wanting to connect better with God in their bodies. And there's some other books here that I recommend as well. So thank you so much for listening and for being a part of this workshop.